next session in the afternoon. My name is Héctor Bueno. I'm the head of clinical cardiology at Hospital Gregorio Marañón. My co-chair is Alex Sionis. He's the head of the ICCU in Hospital Sant Pau in Barcelona. And we have a session, a roundtable on the acute intensive cardiac care. And as Antonio mentioned yesterday in the opening ceremony, I mean, the working group traditionally has been ischemic heart disease, and we've just moved to intensive heart disease and acute cardiovascular care. That is very important because the traditional ICUs do not have so much work and so challenging patients with the increase and reperfusion, and particularly in primary PCI. However, we're having more and more critical patients, difficult patients, challenging patients, and we're moving very much to ICCUs. And I think that we have a table in which some of the critical points of discussion on this particular new setting will be discussed. So we are privileged to have a discussion on cardiopulmonary resuscitation, on the role of echocardiography, and on the role of intra-aortic balloon pumping, which are some kind of controversies or some issues which need to be developed. So with that, I'm gonna start with Kjetil Sunde from is a professor of surgical ICU at the Hospital of Oslo University, and he will be touching upon the initial management of cardiac arrest and the optimal resuscitation.
Thank you very much for introduction. Thank you very much for inviting me back to Spain. It's great to be here. Actually, my first meeting ever in an international meeting was in Seville, and that was in 1996, so it's good to be back here. I will talk about initial management of cardiac arrest. I will focus on cardiopulmonary resuscitation and the treatment before we get ROSC. 2 years ago I talked at the same meeting about hypothermia and post-arrest care, and I will not talk about that today, but we can of course discuss it afterwards if you have time. I have no conflicts except of being an anesthesiologist. Okay, so the background, around 275,000 arrests in Europe per year. It's an incidence of around 35 to 60 per 100,000 people a year. Of those centers admitting data, we have a survival rate that varies from 3 to 31%. So with an overall survival of 9%, that gives us almost 25,000 survivors. And of course, it's a huge challenge for us to get more survivors, and especially more neurologically intact survival, so that they can live a normal life after their arrest. So we can divide the causes of cardiac arrest into two, the cardiac causes and the non-cardiac causes. And the cardiac causes are most frequent. So we know that 70 to 90% have a cardiac cause, primary ischemia or primary arrhythmias. But chronic ischemic disease and acute myocardial infarction are the most frequent direct causes. Approximately 70 to 80% of the patients have some kind of coronary heart disease. And when we compare data throughout the world, it's easier to compare cardiac etiology because all of these non-cardiac causes have a much worse prognosis and are much more difficult to treat and requires more direct related treatment. So we like to compare the cardiac causes, which is the most frequent causes. So if you look at this picture, we can actually see the main cause of arrest. We know actually there is a 70% rule. So the most of the arrests occur out of hospital, 70% occur at home, 70% have cardiac cause, and 70% are men above 60 to 65, interested in exercise. We already had a talk about sex this morning, so I follow up on this one. So these are actually the persons that really should know and learn the CPR guidelines, because she will have to do that in some years, I guess, if he continues with this. Okay, the initial rhythms can also be divided into 4 different rhythms, and they're all causing cardiac arrest. We have a ventricular tachycardia that is very rare, just 0 to 2%. Ventricular fibrillation is decreasing around the world. We have now numbers from 20 to 35%. Asystole is the most frequent cause of arrest. Especially in Asia, it's up to 60% among the primary rhythms. So that's increasing. And pulseless electric activity is in around 20 to 30% of the cases. And the reality during advanced life support in cardiac arrest is really that we do a lot of studies from the end of 90s have shown that we give bad quality CPR out on the scene. Too shallow chest compressions, frequent pauses, and also hyperventilation. And all these factors lead to poor outcome. And we are introducing a lot of devices, and we are also giving drugs that we even not know if they help or not. And I will actually first touch on the drugs issue, because we all like to give drugs, and we like to give drugs especially in very sick patients. But there has been a lot of drug studies in out-of-hospital cardiac arrest patients, and none of these studies have shown any benefit in outcome, in positive outcome out of the hospital. And we did a randomized trial in Oslo in from 2003 to 2008, where we randomized approximately 900 patients to two groups. One was the IV group that got IV medication following guidelines with epinephrine, amiodarone, and the second group was the no IV group. So we came out to the scene and we didn't put in a line at all, and we just focused on CPR and defibrillation. And that study was published in 2009, and there was actually no difference in outcome, no difference in discharge to hospital. Our hypothesis was that this group, the no IV group, would get better quality of CPR because we thought they would focus on quality of CPR and defibrillation. But actually the quality of CPR was equal in both groups, was good in both groups. And we didn't find anything on outcome. But in the IV group here, you can see that more patients got return of spontaneous circulation, significantly more. More patients were admitted to hospital, but there was no difference in discharge out of hospital. And we have good post-arrest care in Oslo. Approximately 50% of the patients that are admitted are being discharged from hospital with a good neurologic outcome. And you can see here the VF patients, there was actually no difference in ROSC or also in discharge rate. So in VF patients, there was actually no difference at all. That means that the major difference was in the non-VF patients, a threefold higher ROSC rate. More patients admitted to ICU, but no difference out of hospital. And you see more patients, actually almost significantly more patients were discharged after the hospital treatment than in the non-IV group. We know that epinephrine causes a myocardial dysfunction, especially if we give a lot of it, and also that it leads to reduced cerebral microcirculation. So although we get patients back, that it might do something wrong with the brain. We don't know that. There was a randomized trial also from Australia, and they found exactly the same. It was a little lower number, and it was stopped a bit early. They had some problems. More patients with ROSC, and the survival rate was very low in Australia here in this study, but there was no statistical difference in survival. So again, more patients into the hospital, but not more patients out of the hospital. And this is a large registry from Japan, 417,000 arrests, and they tried to adjust for all the covariates. We know if epinephrine is given, there is more in prolonged arrests than in short arrests where you have no time to give epinephrine. But still in their multivariate analysis, epinephrine use was associated with worse outcome compared to using epinephrine in these patients. So the European Resuscitation Council admitted in 2010 that although we still recommend drugs, we don't know the optimal dose. We don't know much about pharmacokinetics, and we don't know how long we should give CPR after giving the drug. So there are a lot of knowledge gap regarding drugs, and we need to do more research on this. So we emphasized in 2010, although drugs and advanced airways are still included among ALS interventions, they are of secondary importance to early defibrillation and high-quality uninterrupted chest compressions. So that leads us back to the basics. That's the most important thing, to give good quality CPR and early defibrillation. And that is all summarized in this chain of survival, which really is the important step to know and understand and follow if you have a cardiac arrest victim. Early recognize, early CPR, early defibrillation, and then early and good post-resuscitation care. And again, I will focus on these links in the rest of my talk. So here you can see the importance of early defibrillation. We know that from each minute it goes until we can defibrillate, survival will decrease with up to 10%. This is from the Swedish registry. These are numbers from 10 years old now, but still they're still actual. And you can see here in the dark are those patients admitted alive, and here are those patients alive after 1 month. And here on the x-axis you can see time from arrest until defibrillation. And you can see here, these are the numbers from Oslo before 2000. And we had, we defibrillated after some 11 minutes. Response time of 9 minutes. We defibrillated the patients after 11 minutes. And we had a survival rate for around 8% in Oslo. So it fits pretty well. In 2 cities in Norway, they had a shorter response time. So they defibrillated the patients after 8 minutes. And they also documented a higher survival rate of approximately 18%. Fits well with the data. Seattle are the world champions in today. I mean, they have defibrillators all over the place. In Rochester also they have good survival data. Seattle like to say that they are the best. I guess they have a fight in the US. But still, they defibrillate the patients after some 5 minutes. And you can see the survival is approximately 25 to 30% at least at that time. But the best survival rate in the world actually is from Las Vegas, from the casinos in Las Vegas. They have put out AEDs all over the casinos, and there were more than 100 arrests in this, and they showed a survival rate of more than 50%. And of course, if you have lost a lot of money and you get cardiac arrest, the people in the casino want you back so that you can pay, of course. And that's a reason why they have, I guess, all the AEDs all over the place there. So again, but that shows us the importance of early defibrillation. I think everyone understands that. So what about early CPR? Here again from the Swedish registry, this is without early CPR and this is with early CPR. And if you can add early CPR, you will double the chance of surviving cardiac arrest. And early CPR does 2 things. It maintains blood flow to the brain and the heart, which are the 2 really important organs we care about. But it also maintains VF. So if the patient has VF and you start CPR, you will maintain the VF. If you don't start CPR, the VF will go into asystole after time. And of course, the chance of a successful survival will be a lot reduced. So you do 2 important things when you do CPR in these patients. So how do we optimize these chest compressions? If you look at the heart, it's easy to see, and I think you all know, you are cardiologists, that the right side is more thin-walled than the more thick-walled left side. So the important thing when we do chest compressions is to get the blood out of the right side and to empty the right heart, which gets dilated in the early phase, and to get the blood out in the left, from the left heart. And of course, it's very important that you compress both sides of the heart, and especially if you do it too shallow, there will be no movement on the left side, just on the right side. So it's very important that you also remember that the cardiac output has to be optimal. So the rate has to be somewhere between 100 and 120. If we go too fast, there will be no filling of the heart. So between 100 and 120 is the optimal rate, and you can sing Staying Alive from Bee Gees, because that has the rate of approximately 100. Of course, it has to be deep too. As I told you, it has to be deep so that you can get the blood out into the system. So the force has to be some 5 to 6 centimeters to get effective circulation out. And then you also can think about Bee Gees, because they have another song, How Deep Is Your Love? Can't keep a good man down. So of course, Bee Gees is really the cardiac arrest group that we have to use. Then the duration, the compression, that means the compression time and the relaxation time. And we like to say that the brain is perfused during compression and the heart during relaxation. So it's important to have 50% of the time for each cycle, so that you can say brain, heart, when you do CPR and sing Staying Alive and have a really good time. So that makes all cardiac arrest pretty interesting to deal with. And then you have to avoid leaning. That means you have to take your hands off the surface, because that impacts on the intrathoracic pressure and will then also get less blood back to the heart. So you have to avoid leaning. And also, of course, as few and short pauses as possible. Every time you stop CPR, circulation to the heart and the brain stops. So those pauses has to be as short as possible. So this is really the most important slide of my talk. Quality of CPR is of utmost importance. What about ventilation? Do we need to ventilate? We have chest compression only CPR, which works, which is effective. And of course, circulation, that means chest compressions, is of course much more important than ventilation. So especially in patients with cardiac cause, and especially in dispatch-guided CPR, if an older woman or a person calls in and they don't know how to do CPR, they will never manage to do ventilation, but they will manage to do chest compressions. So that's the reason why we say in these two circumstances, of course, chest compression only is better. But what about asphyxial arrests? What about children, newborns, all those hypoxia arrests? They need ventilation, and they need ventilation early. And this is actually a study we did in our lab some 10 years ago, where we looked at chest compression only in black and ventilation with normal air, 20% oxygen. And we saw that just after, this is the arrest time here, just after 1 minute, you can see the oxygen saturation was lower than 40, and after 2 minutes, it was really down to less than 20. And here, if we had normal ventilation with normal air, it was at least maintained at around 80. So ventilation is needed, and especially over time. If arrest prolongs, ventilation is needed. But in the early phase, if you have a cardiac cause, of course, compressions are important. But after some minutes, you really should start with ventilation. So before intubation, 32. After intubation, you can do continuous chest compression and interpost 6 to 10 ventilations per minute. But if you're not able to do ventilations, then skip it, do chest compression only CPR. How can we monitor the quality of CPR? If we intubate our patients, we can use the capnography that we use every day in the ICU, in the anesthesiology department, because capnography estimates cardiac output. I mean, circulation produces CO2, and we can measure that. And actually, that was first presented already in the 70s by Calenda. And he used capnography to say that this is a cardiac arrest patient, and here it declined. So they said, here was fatigue, we need to change the provider of CPR. And look, it gets better again. And here they changed again, and it's easy to follow and to guide the providers when they do CPR. So if the capnography level is low, you should try to improve the quality of CPR or change the provider. And it has been shown in several studies from throughout the world that end-tidal CO2 is associated with outcome. The higher end-tidal CO2 you can achieve, the higher the ROSC rate, the higher the survival rate. It's not a cutoff value that you can use, but you can use it in single patient to see if you can improve the capnography. And if it stays very low, you probably won't get the patient back. And it's also an excellent tool to differ between PA and ROSC. Imagine you have shocked the patient and something happens with a rhythm and you're not sure if this gives a pulse or not. And if you have capnography, you will easily detect a curve if you have ROSC, and there will be nothing if there is a PA. So again, capnography is very good to use during resuscitation. Then we have these mechanical CPR devices. We have two devices out there. We have the Autopulse, and we have the Lucas devices. And they have been used in the lab showing improved hemodynamics compared with manual CPR. And now there's actually been two big randomized trials out there published last year. This one with Lucas, it's a multi-center, the LINK trial, where 4-hour survival was their primary outcome, and it was no difference in outcome. And also in later outcome, there was no difference in outcome. So equal results in manual CPR and mechanical CPR. And the same thing happened also for the Autopulse trial. You see here big trials, 4,000 patients in US and Europe. And there was actually a trend towards better survival in the manual group, but when they adjusted survival to discharge, the odds ratio was 1.6. So there is actually no difference in survival here in these groups. And you can see here, the quality of CPR has improved a lot the last year. 80% of the time, they are on the chest giving circulation to the patients. And exactly the same in a mechanical CPR. So that's good CPR. So to conclude about mechanical CPR, we can say there is no difference in outcome between mechanical CPR and manual CPR. It is possible to perform good quality CPR with manual CPR over time. You should monitor it with capnography and change the providers. And we don't need a mechanical chest compression device in each ambulance or for each resuscitation attempt, which I think is very good because manual CPR is good and it's easier and it's easy to train. But we should have a mechanical CPR device available because they can be used during transport. During transport, manual CPR is totally ineffective. And also, we can use them as a bridge to more advanced therapy. And especially if you have a cardiac arrest that happens in your cath lab, or that might be an option where you can use the mechanical CPR, because you can actually use mechanical CPR during coronary angiography and also during the PCI procedures. We did a study published in JACC in 2007 in pigs and also in some patients where we showed the feasibility of this method, and it has been used in several cases. And here actually you can see a patient that came in after actually some 1.5 hours after his arrest. It was a young guy that had chest pain and got cardiac arrest. And I think we all can see the occlusion here that caused his arrest. And of course, it makes no sense to defibrillate this patient, to give him a lot of epinephrine if you can't open this vessel. So this was done in this patient. This is 5 minutes later. And you can see here, blood flow is established. The Lucas device is going here. And now you can defibrillate the patient. The problem with this patient, that procedure, we discussed too long with the cardiologist. We discussed for more than 1.5 hours in the emergency department before we took him into the cath lab. So, I mean, it was impossible to save him. But with an Impella, ECMO, and also transplantation, we might have saved this young guy. And actually, ECMO is more and more interesting now, and especially in Asia, but also now in Europe the last years, it has become more and more popular to use ECMO in refractory cardiac arrest. Those patients like this that we can't get back, can we still save them? And this is what they did in Belgium. It's 24 patients with refractory cardiac arrest where they used mechanical CPR into the hospital. There are both out of hospital and in-hospital cardiac arrests here. But they took the patients fast. After 10 minutes of ALS unsuccessful, they decided to take these patients into the hospital, establish ECMO, and if they could establish ECMO fast, that means within 1 hour, they had survivors. You see they have 6 survivors here. But they also had 4 donors, at least possible donors for this system. And I know that you in Spain and in some places use Lucas device to get also 2 donors. So there are 2 possibilities here. So of course, primary, you want to save the patient, but you might also get donors out of this. So this is coming more and more interesting, this field. And I think Malcolm Bell will also touch on this in his talk. So just 2 slides about post-resuscitation care. I talked about it 2 years ago. It's very important to have a decent post-resuscitation care strategy. And this is again from the Swedish registry. And I think each bar represents a hospital. And I think all of you would have been admitted to this hospital where 40% of the patients are admitted among those, 40% are discharged among those admitted, compared to this hospital with just 10% outcome. So of course the quality of post-resuscitation care matters. And I hope that you all have a system with early coronary angiography, initiate target temperature management, and optimize hemodynamics. Induction phase, fast, then maintenance phase. At 33, we have a new study now. We can perhaps discuss it afterwards. What is the optimal temperature, if it's 33, 32, 34, or even 36? And then we have a rewarming phase. And during this whole period, we really need to care about our patients, have a standardized treatment targeting different goals. So these are the main targets that we have to follow. We have kind of summarized this in a provocative paper that we were given. And of course, drugs, we don't have evidence today. Good quality of CPR is much more important. But there really are some new concepts that might provide a more tailored therapy and improve outcome in cardiac arrest. So future research needs to incorporate better diagnostic tools to test more specific and tailored therapies that account for underlying causes and individual responsiveness. So how can we then improve the survival? Again, we have to dig into this chain of survival, document the survival rate in our system, critically assess the local chain of survival, and then ask the two crucial questions. Are we happy with the survival rate inside our institution? If you're happy with 2% survival, you don't need to do anything. But I hope that you are not happy, and you have to identify the weak links. Where can we improve in this system? And there are a lot of things that you can improve. These are 71 single factors within the chain of survival that you can go into and see if you can optimize this. You can find some of them, and just by improving some of them, you can improve survival. We have done that in Oslo the last 10-15 years, where we first improved the quality of CPR, then we improved the quality of post-resuscitation care. And you can see here, among all cases, survival has doubled, despite longer arrest times, less initial VF. And you can see here, among cardiac causes, from 10% up to 20% survival, and VF arrests from 15% up to 35% survival, by improving the quality of CPR and post-resuscitation care. In Seattle, they are not even satisfied with their survival of 34%, so they digged into their system and improved the second and third link with even more early defibrillation and telephone-assisted CPR, and they also could improve outcome by focusing on weak links in their local chain of survival. They have done the same in Japan, improving citizens in CPR, EMS defibrillation, EMS intubation, have improved survival over a 10-year period. And this is a system-based approach from Minnesota in the US, where they have focused on improving the whole chain of survival, trained citizens in CPR, goal-directed training for paramedics, and 3 cardiac arrest centers with 24/7 PCI and hypothermia. And also they could show a more than doubling in survival among their patients. And this is the last paper showing this from Denmark over a 10-year period, and in markedly improvement in survival in Denmark, and especially due to more bystander CPR. You can see also here that hypothermia was initiated in 2004. You can see that here. But still, bystander CPR has increased, and they really focus on bystander CPR in schools and also when they acquire a driver license. So I think the important thing is to optimize CPR, the local chain of survival. This is the Norwegian chain of survival. And consider cardiac arrest as a journey that occurs at home and goes through bystander, dispatch center, ambulance, emergency department, ICU ward, and back to home. And that is like a relay where all 4 steps has to work and optimize together. If one of those 4 steps are not working well with you, you will lose. You will never win gold. And that's the same thing with cardiac arrest management. So you have to identify the weak links and make easy practical protocols. Training, both in the hospital and outside the hospital, and also, of course, think about the implementation strategy. And I think Obama, I will not be political, but Obama said something very important. Change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek. And if you take that seriously in cardiac arrest, you can keep on singing Bee Gees, because you will get more survivors. Thank you.
Thank you.
And I will come back to Spain in 2 weeks. There will be can you take the last slide, please?
No.
There will be a European Resuscitation Council meeting in Bilbao in the middle of May. So if you're interested, you can come up there to all the flowers. Thank you.
Thank you. So, is there any comment or question from the audience? If not, I would like to ask you, do you have any information about, I'm going to ask you particularly in hospital, about the quality of CPR in hospitals, in general, in cardiology departments. Do you have any information? Do you think that is something which we need to be worried about? And do you know if, in general, this quality assessment systematically in hospitals and cardiology departments?
Yeah, you should be worried about it. It should be improved. And there were 2 papers in 2005, one from and that was a multi-center trial, one from Chicago, one from Norway, but they were multi-center. One was out of hospital and one was in hospital. So the Chicago paper was concerned about in-hospital cardiac arrest. And the quality of CPR was bad in that papers too, among doctors, among nurses, among everyone. And they followed, of course, the 2000 guidelines that led also up to pulses. But the compressions were too shallow, and we didn't optimize it. And there has been papers showing that if the pulses are long, if the rates are too slow, if the force is too low, you have fewer survivors. And again, this is the most important thing. When I have a cardiac arrest, I look at the one that provides cardiac CPR, and if that's too bad, I say, you have to improve. This has to be done better. And it's much, much more important than giving drugs or doing all that stuff that we do.
So if you were an administrator and a politician, what would you force to do in hospitals in terms of ensuring quality on CPR?
I mean, we have courses at least in our hospital, so that all nurses have to do a course at least once a year to certificate themselves, both in defibrillation, CPR, but also in advanced life support. So I think, of course, quality of CPR and courses, of course, you should really focus on that.
Well, if no one has a question from the audience, I have a question for you, Kjetil. Then I was wondering really about bystander PCR. That's a big issue. And I was wondering how you have addressed this issue in Norway. Because I know that, for example, in some states, in the United States, it is compulsory in high schools to have a certification in basic life support. How is it being done across Europe?
Yeah, I mean, there are differences. In Norway, this bystander CPR rate has always been very high. In Oslo, it has been around 50%, but in Stavanger and also in Tromsø, in northern Norway, it's 75%. I'm not sure why. It seems that the people care about each other and they like to kiss foreign patients, foreign people that they see on the street. I'm not sure. But I think, we have always had bystander CPR training in schools and also in driver license, and it's a focus on it for example, if you open the telephone book in Norway, on the second page there is CPR guidelines, how to perform bystander CPR. And we are very keen on getting this out to the people. So if we have really positive cases, we try to contact the media, television, newspapers, all over, show it so that it really helps. I mean, we have kids of 12 years old that have saved their fathers after cardiac arrest, and it's really important to get this out. So you slowly have to start campaigns like they did in Denmark to do something. And for example, in the United States, in UK, they have this chest compression only campaign. And of course, people are perhaps afraid of, again, ventilation. But of course, to do CPR cannot harm anything. It's also not dangerous to give mouth to someone, but of course I understand that you don't want to do that on everyone. But at least these chest compression only campaigns helps and helps saving a lot of lives around the world. So it's really something that we should take seriously. But it doesn't help with PCI and hypothermia and all that stuff if the pre-hospital phase has been too bad.
See, one last question. Yeah. No. So I'm going to make it, and then just get into what you just mentioned about PCI. So I'm having hard times in recommending, and we do PCI for the patients who come from hospital cardiac arrest after defibrillation with ST elevation, but I'm not quite sure whether we should go for PCI systematic to all patients resuscitated. What is your view about that?
It's an important question, and a lot of people around the world concerns about this, and I was just in Belgium where we had a debate about this. It's no doubt that STIMIs should go to cath lab immediately. But there are more and more data showing also that end-stage mice have culprit lesions. From the data from France and also from Slovenia, and also we have a study now, show that 20 to 30% of the end-stage mice have an acute culprit lesion and should be getting an acute PCI early. And for example, we have done a study where we took 250 patients to the cath lab, all cardiac etiology, and two cardiologists independently, without knowing the results of that, judged the ECGs on admission and said that one should go, that one should not go. And it was a chaos. You cannot identify the patients in STEMI that really benefits from a cath. So we have a pretty high number in our institution. Approximately 70% to 80% of all cardiac arrests with cardiac etiology go to cath lab, and approximately 50% receives a PCI. If we should take all, we really need a randomized trial on this, I think, for the end-stage mice. A multi-center randomized trial that would really give the definitive answer, I hope.
Yeah, thank you very much.
Well, our next speaker was supposed to be Dr. Susanna Price from London in UK. Unfortunately, just the day before yesterday, she suffered a foot injury and she had to get some surgery for it. So she has not been able to travel over here. And luckily, she was able to convince her fellow, Dr. Ana Martinez, to step in for her and save the day for Hector and I. So it's a pleasure for me to introduce Dr. Martinez, who is currently a fellow in image and critical care at the Royal Brompton, London. Anna?
Hi. Good afternoon. Thank you very much. Unfortunately, Susanna is not here today, so I'm apologize in her name, and thank you very much in her name. I'm going to try to explain the role of echocardiography in critical cardiac care based in our experience at the Royal Brompton Hospital. And the first question is, there are new applications about echocardiography in critical care, and we can summarize it at not really, but let's see. Several publications since 14 years ago say about the important role of echocardiography in diagnosing patients and also changing the therapy in these patients. Because pre-hospital emergency echocardiography changes up to 60 to 80% of treatment in this setting. And more recently, echocardiography has been involved in the definition of acute myocardial infarction, and even more recently has been included in the guidelines of resuscitation guidelines in cardiac arrest. So echo is useful in monitoring. Here we can see that echo correlates in estimation of cardiac output with the pulmonary artery catheter, and also is good in physiology, for example, measuring the wedge pressure, and is useful in perfusion and assessing ischemia, and is useful as well, of course, in assessing anatomy, both in 2D and 3D techniques. So this is the potential scope of echocardiography in critical care setting. Is there are lots of parameters where we can assess with echo, but everything is not good, and there are some challenging and some limitations that we have to know. For example, in the patient in the left, maybe he has not the best ultrasound window in the world, and in this patient in the right, maybe the TE could be contraindicated. So sometimes the limitations are given by the patients. Sometimes the limitations are the proper pathology of the patients, and in critical care, mainly the severe lung disease is the big problem. And sometimes are the proper ITU interventions, for example, in patients that are prone or with a huge monitoring that we cannot do, even reach the patient with the probe. So And the last, and not less important, is the temporal limitations. For example, in a peri-arrest or cardiac arrest, we cannot spend 1 hour seeing what's going on with the patient with a blood pressure like that, and we have to be quite fast. So the most important thing of the echo in the critical care is interpretation of the data in the clinical context. We have to have in account ventilation status, filling status, inotropic status, metabolic status, all of that. It's very important because we don't know what's the normal parameters in patients in the critical care, because all of these patients are excluded in the randomized control trials. So for example, here we have a clinical scenario where we have a 52-year-old man with 2 weeks post 4th time redo mitral valve replacement, blood pressure and heart rate, but the patient feels unwell. There is a renal impairment, and there was done a TT, a transthoracic echo in the ward. Here we have a video. Yeah, that shown that it's very bad ultrasound window with moderately impaired LV function, but no features of cardiac tamponade. The patient was transferred to the ITU for diagnosis and treatment, and TOE was done, transesophageal echo, and we saw a big collection posteriorly located to the RV that is compressing, so the patient was transferred directly to the theater. Because sometimes a normal echocardiography and normal Doppler parameters in the transthoracic echo are missing some cardiac tamponade, and because these patients, mainly in postoperative patients, because of the sternotomy, they have a very bad window, and sometimes are collection posteriorly located that we can miss. So the threshold to go to the theater with this patient has to be very low. There's another clinical scenario. This 19-year-old man with trisomy 21 with normal echo style, but he was admitted for a severe pneumonia, and was done a transthoracic echo that showed large pulmonary artery. The patient was transferred to the National ECMO Center for extracorporeal support, and a transesophageal echo was done that showed an ASD. Actually, there are 2 ASD. Actually, there is a AVSD. So maybe this was the cause of all of that, in top of the pneumonia. And the last one is a 46-year-old man with, again, pneumonia, and he was ventilated for 6 weeks with this X-ray at the 6th week. And he was diagnosed of ARDS and transferred for attempt weaning of ventilation. And the patient has had a past medical history of mitral valve replacement 10 years ago. So, well, I don't know where this video is going, but here it's supposed to be a 3D video of paraprosthetic leak. But this was the cause of the difficulty of weaning of ventilation. The weaning of ventilation is one of the most difficult things in the critical care setting, and it depends on the patient population, but it can reach the 83% in the ITU patients. And it's supposed and implies a huge impact in patients, but also a huge impact in economy. And another challenging, another difficult thing is determining the cardiac contribution in this difficult weaning from the ventilation. And all of these factors can be leading to a respiratory distress, but with the echo, we have to, the most important is to pick up the alveolar edema that might be or might not be cardiac in origin. So the question we have to do to ourselves is, are evidence of increased left atrial pressure at the moment of weaning from ventilation? All of you, I'm sure, that are very familiar with these parameters of diastolic dysfunction and assessing left atrial pressures. But all of these parameters, there are a lot of publications in non-ITU patients. There are some publications now in patients in the ITU setting. And in this paper, for example, they concluded that some data as a mitral EA ratio less than 1.4 and a systolic diastolic ratio in pulmonary veins more than 0.65 and systolic fraction more than 44% predicts a pulmonary artery occluded pressure less than 18 millimeters of mercury. So sometimes we can assess also with these parameters the left filling pressures. And we have to pick up potentially reversible factors in this difficult weaning from ventilation. Because in the weaning from ventilation, there is a reduction in sedation, increase of work breathing, increased heart rate, increased blood pressure, increased systemic vascular resistance, and increased PCP. And we have to know that different types of ventilations have a different impact in the hemodynamic of the patient. So all of these factors can be leading in a critical mismatch, blood supply, inotropy, chronotropy, or mismatch in loading, and can be causing the difficult weaning from ventilation. So can we check these difficult and potentially reversible parameters? Yes, some of them we can with an echo. For example, myocardial ischemia, the inotropy mismatch of the uni or biventricular inotropies, the chronotropy mismatch as well as AV synchrony, intraventricular synchrony, and the afterload and the preload we can assess. What are the tools we have to assess that? For example, we can do a transthoracic echo. The pros are that we are seeing what we are doing at this moment, what is going on with the patient at this moment. But we have some limitation as the tachypnea, tachycardia, and we cannot use a transesophageal echo because we are weaning the patient. We can use a dobutamine stress echocardiography that is very good assessing ischemia, and the LVOT obstruction as well, of course, but this is not a real situation of the patient, and we can develop some arrhythmias. And also we can do a volume pressure challenge. It's very good picking up a dynamic MR, but we have to do it very carefully because we can precipitate something like that, as it was a mild MR in the beginning, but after the preload, after the volume challenging, was a severe MR. Chronotropy mismatch is something important in the critical setting because we know that duration of systole is relatively fixed, but the time required for diastole varies, and the contribution of atrial systole varies with pathology as well. So optimal heart rate and AV interval varies with pathologies. There is an important concept, as is the mechanical dysynchrony, that is given by the time that the heart is contracting effectively. This time is given by the ejection time and filling time, and the rest of the time is wasted. We are not, the heart is not contracting effectively. So this time wasted is the total isovolumic time, and if this time is more than 14 seconds in 1 minute, I mean, if in 1 minute we waste 14 seconds, there is a global LV mechanical dysynchrony. This occurs in 23% in the ITU patients, But optimizing pacing in these patients, we can increase systolic volume to 36% in these patients. So it's very important to optimize. We have one example here. For example, here we have patient with PR interval 250 milliseconds. The MR is very long, 500 milliseconds, with a presystolic MR. And here we have the Doppler waves with the filling time and ejection time. The filling time is very short, and the two waves are together, and the ejection time is short as well. So we have a total isovolumic time of 29 in 1 minute, 29 seconds in 1 minute, so it's huge. And in the same patient, after a patient, the patient was a postoperative patient with the pacing wires, epicardial pacing wires thing. So we decreased the AV delay to 100 milliseconds. The MR is still long, but it's shorter than before, 460 milliseconds. And now we have the two waves separated, and the ejection time is not much bigger, but a little bit better. And this isovolumic time is 18 seconds in 1 minute. That is not perfect, but it's much better than before. Another important concept is resynchronization in the critical care. Patient has been proven to be as good as dobutamine in improving cardiac function. Here we have this graph with DPDT, that dobutamine and pacing improve the same, but pacing is not increasing the MVO2 adjusted by heart rate. So that's important to know. And there are some publications in this direction towards the biventricular patients in patients that are in the critical setting, and are patients that are in the end stage of heart failure, and we cannot manage with the normal support. So sometimes we have a very good outcome in this biventricular patient. And the last concept maybe is not forget the RV, because the RV exists and is important in the patients, in ventilated patients. The RV failure increases the risk of mortality. Here, they studied patients with ARDS, and in 100 of them, they developed acute cor pulmonale. Right ventricle failure correlates to plateau pressures, but they found that with plateau pressures less than 27 centimeters, they still have right ventricle failure and acute cor pulmonale in 13% of patients. So it's very important to monitor right ventricle in ventilated patients. So training and certification in echocardiography in critical care, it's completely different from outpatient echocardiography. There are two levels of competence, and there is a strong recommendations in all cardiologists involved in the IT units to undertake additional training to the normal training in echocardiography. And also there are strong recommendations encourage sonographers and fellows not to routinely perform clinical echo unsupervised. So the last slide is just some messages. Critical care echocardiography is different from standard echocardiography. Challenges exist relating to patients, pathology, time-critical scenarios, complexity of diagnosis, and lack of evidence in critical care setting, and should not be regarded as simple, but recognized for the complexity and challenge that critical care present. Thank you very much.
Thanks, Anna. It was a great talk. And I have a couple of questions for you. The first is, I imagine that as it happens in Spain, also in the UK, there is a huge debate about who should perform echocardiography in the critical care setting, because what you showed here is really advanced echocardiography. I don't think even a cardiology that has received a strong clinical training in cardiology could do some of the stuff you've just shown. So do you think anesthesiologists and intensivists should do echo? And or better, I will rephrase my question. Do you think this kind of echo is what all intensivists should do?
Well, this is a difficult question, but for example, in our unit in the Royal Brompton, they are running by intensivists and anesthetists. So sometimes in a cardiac arrest, there is no time to call for the SPR in cardiology to just go with the echo to see if the patient is tamponade or not, or to see if there is something going on. So I think that sometimes it's important for these patients that are in these units to have some knowledge in echocardiography. Maybe advanced concepts of echocardiography, physiology, or I don't know, some advanced techniques are not in this environment, but I think that some concepts are very used for them because there is no time to call.
I totally agree with you. I mean, standard echocardiography is obviously a must for anybody involved in the critical care, but some of the things you've just shown are out of the league probably. And then I was going to ask you something about the, you talked about alveolar edema, about when you're assessing the weaning from mechanical ventilation. You've showed some things about echocardiography. Could you comment something about pulmonary echography in these patients? Because pulmonary echography can also be quite useful in assessing alveolar edema.
Yeah, well, I'm not very familiar with lung ultrasound, but they are people in my unit. They are doing some lung echocardiography, and they can see if the lung is more wet or less wet. So I think it has a role that is not very well developed, but I think there is a role in this lung ultrasound. But I'm not very familiar, I have to say.
Any questions from the audience? Okay, thanks a lot. So I think we can move on.
So the last speaker is Malcolm Bell. So he's back again talking with us. I mean, as you know, he's back here not because he's our friend that he's been for many years. It's not because he's a Real Madrid fan, of course, after Everton, at least for some of us. It is not because he has a beautiful wife, which he has, but it's not the reason. I mean, the reason why he is here, and you also perceived that this morning, is that he has this fine clinical approach to the evidence, to the controversies, and I think he's the perfect person to discuss this issue of the finding that the shock trial showed no benefit with intra-aortic balloon pumping, but I think there's, at least in a wide number of hospitals, this discrepancy between the evidence and the clinical practice. And I know that Holger Thiel is not using balloon pumping anymore, but I can say that at all that's the routine in many hospitals across the world. And I think that Malcolm can tell us his view about what is the evidence and what is real life, and how, if we can conceal these differences or controversies.
Well, I certainly hope so. Thank you so much, Hector, for those very kind words, and also Alessandro. I think that when you gave me this topic, my first thought was this is an excellent topic to discuss, and I jumped at the opportunity to do this. It was much better than the previous topic you'd given me, something about stem cells. But I hope that I can answer this question, certainly to your satisfaction, Hector, but obviously more importantly to our audience. So you've already set up the talk very nicely with your reference to the IABP SHOCK 2 trial. Again, I have no conflicts or disclosures to make. And this slide here just summarizes what I see as the current utility of balloon pumps in our clinical practice. And I'm going to spend most of the next 20 minutes or so talking about cardiogenic shock as a complication of acute MI. I'll spend a few minutes talking about high-risk PCI. Time does not permit a discussion of the use of a balloon pump with mechanical complications of an acute MI. I can tell you we still use intra-aortic balloon pumps in patients who are in shock and are going immediately to the operating room, who have like ruptured papillary muscle, for example. And I can also tell you that in our practice, in our cardiac intensive care unit, we are increasingly using intra-aortic balloon pumps in patients with advanced heart failure who are just a few millimeters of mercury or a few seconds away from full-blown cardiogenic shock, who are patients who are being prepared for an LVAD or undergoing very, very high-risk cardiac surgery. And I can tell you that in following the hemodynamics, and particularly the clinical picture of those patients, they certainly seem to derive some benefit. And our surgeons are very keen on using these devices. And we've actually seen an increased number of balloon pumps used in that population. But let me start with a clinical case. This is a 50-year-old gentleman who had a witness out-of-hospital cardiac arrest, successfully resuscitated. He's mechanically ventilated, and he arrives in the emergency room, but he remains hypotensive despite the administration of ample fluids, and he's on norepinephrine. He's received minimal sedation. He's tachycardic. You can see that his systolic blood pressure is 70. He has a MAP of 54. He's cold, he's clammy, and he's drowsy. So this is his electrocardiogram. He's having a massive anterior STEMI. There's no question here. But the question for the audience is he is sent for primary PCI, but in addition, what would you recommend? Placement of a balloon pump? Hands up. Okay. No balloon pump? This is assuming everyone's read this. Well, we have one person who's not going to put a balloon pump. Percutaneous LVAD, impeller, or enroll the patient in a randomized controlled trial, intra-aortic balloon pump versus nothing. Hands up. Good, because without those two people, we couldn't run a randomized controlled trial. And so let's just quickly look at a couple of things about shock. I think that these are data from the Swiss AMI trial, and showed that the overall incidence on an annual basis of cardiogenic shock appears to be decreasing. And we've seen similar trends in the United States. Perhaps this is a little lower than what we've seen in the US. And I think that this is important for us just to take note of, but it still occurs. For all of those of you who work in the cardiac intensive care unit, the coronary care unit, I'm sure you still see a lot of shock. And maybe this decrease in incidence is due to more widespread use of reperfusion therapies. Who knows? But let's not dwell on that. Let's look at the mortality. And despite the fact that there may have been some slight trend in reduction in mortality over the years, these are data from the NERMI registries, so a couple of 100,000 patients represented here, and those who had shock. But you can see here that the mortality remains very high, at least 40% or so in the younger patients, but staggeringly high in the elderly patients, 60 to 70% mortality. So on this slide, what I'd like to do is just really, I'd like to summarize what our main goals of treatment should be with shock. because no discussion about the treatment of shock can be had without emphasizing the importance of early and rapid reperfusion. So it wasn't so long ago that people were challenging the notion that you needed an intra-aortic balloon pump for the treatment of cardiogenic shock. And on this slide, what I've summarized is a very nice meta-analysis published 5 years ago now, showing that overall there appeared to be, and these are retrospective studies, so there's a meta-analysis over many years, that overall there appeared to be a reduction in 30-day mortality. But that was really only evident in the patients who did not undergo any reperfusion therapy or in those who had undergone fibrinolytic therapy. Interestingly, in that meta-analysis, in the population of patients who had undergone primary PCI as their mode of reperfusion therapy, there did not appear to be a survival benefit when a balloon pump was placed. So that was something that challenged our notion of using intra-aortic balloon pumps routinely in these patients, and particularly challenges the guidelines, which at that point had recommended this as a class 1 recommendation that an intra-aortic balloon pump should be placed. So with that as a background, here's the study that Hector referred to earlier, the IABP Shock 2 trial, a very large German study. And I'm just going to summarize the results on this slide here. This showed in randomizing patients to intra-aortic balloon pump or no intra-aortic balloon pump that there was no reduction, no difference in 30-day mortality when an intra-aortic balloon pump was used in patients in whom an early revascularization strategy was employed. Very important finding here. As I said, it was a large trial. To my knowledge, this is the largest randomized shock trial that's ever been performed. In addition to this, some secondary endpoints. There was no difference in lactate levels over time. There was no difference in hemodynamics. But most importantly, no reduction in the mortality. So I'm going to provide a little bit of a critique here, but I'll start off by saying that the investigators need to be commended for performing what I think is an extremely good study. These are incredibly challenging studies to perform, as you can imagine. And as I said, this was the largest shock trial performed to date. They had very high recruitment. And just keep that in mind as we think about recruiting these patients. And I think only maybe in the resuscitation world is it perhaps more challenging when we're trying to randomize patients on the street, with bystander CPR, etc. So the first question I ask is, were these patients really high risk? Were these really patients who had profound cardiogenic shock? And it's interesting to see that the median MAP, or the mean arterial pressure, was 69. Went up a little bit after PCI. So that was the median MAP at the time of entry into the study. Now, a MAP of 69, if you work in the intensive care unit, we're very pleased with that. 60 to 65 is often our target pressure in patients who we're trying to resuscitate. So the first question to ask is, well, maybe there were many patients in this study who weren't so sick. Although interesting, compared to the original shock trial, performed, must be 10, 12 years or so ago now, the pressures are not too different. But anyway, just we'll keep that in mind for a moment. 42%, so less than half the patients had anterior MIs, and most of these patients are the ones that we will see shock in if it occurs. But 25% of the patients, their culprit vessel was listed as the right coronary artery. And so that immediately brings up the question of whether or not in this trial that there were a significant number of right ventricular infarcts. This was not reported in the trial. And as you know, unless the patient is having a massive inferior MI, then the resuscitation really has to focus on the right ventricle and not the left ventricle. But in the most complex cases, it's both, of course. The other point here is about 40% of the patients were survivors of out-of-hospital cardiac arrest, a little bit like the case I just showed you. So then the question is, were they receiving some anesthetic agents for sedation, and how much did that drop the patient's blood pressure, and is that truly cardiogenic shock? Those patients will usually improve with administration of phenylephrine or norepinephrine. Let's compare them to the original shock trial. Again, this was published in 1999 by Judith Hochman. And just to remind you, particularly the younger members of the audience here, this was a trial comparing early reperfusion therapy with either PCI or bypass surgery versus no reperfusion therapy. And in this trial, almost all patients got an intra-aortic balloon pump. But it was a pivotal trial, and it really drives the way we treat shock today. But compared to that shock trial, in this current shock 2 trial, there were fewer anterior MIs, there was less three vessel disease, less left main, and the mortality was a little bit lower. But 40% versus 47% over a period of 12, 14 years is maybe not too different. Another issue is the question of crossovers. Now, you can see here that in the control group, 10% ended up getting an intra-aortic balloon pump. In the intra-aortic balloon pump group, a small number of patients didn't get an intra-aortic balloon pump. Most of these actually had died before they could actually have it put in, or there was some peripheral vascular disease that prevented the advancement of the catheter. But this is the worrying thing a little bit, and just, again, this is not to be critical of the investigators. This actually, I think, underlines the challenges of performing such a trial, and particularly in a country like Germany, where I understand that there's a lot of interest in using percutaneous LVADs. But you can see here in the control group, the physicians taking care of the patient felt that in over 7% of patients that they needed to put an LVAD in percutaneously rather than just keep them as a control patient. And this is one of the problems when, and just, I guess, part of doing business when you're running an open label, unblinded trial. And that brings us to the question of the trial design. Obviously, you can't blind the patient. You can't blind the physician. And just keep this in mind because we tend to sort of accept randomized controlled trials as the gospel and that everything stops and we should believe everything with a randomized controlled trial. But this is not the same as giving a drug versus a placebo and having everyone blinded. It's very clear to the people looking after the patient that they've either got a balloon pump in place or they do not have a balloon pump in place. Now, fortunately, mortality was the primary endpoint of the study, so one can't really argue with whether the patient died or didn't die. But I don't think we can totally rule out maybe unknown confounders that may have led to different treatments in these patient groups. I just don't think we can tell. And so it's important to keep in mind that a control group, as was used in this study, is not the same as a placebo. There was no sham treatment here. But you can't get away with any other trial design. I don't think we should dwell on this too much, but I think it's just something to keep in mind. And then finally, some subgroup analyses. Interestingly, and I think that the authors of the study were very careful, and I agree with them that they say that these are hypothesis-generating findings. But again, as we look at the results of this trial and how we might implement this in our practice, keep this in mind. There was a reduction seen in the younger patients under the age of 50 and in those patients without a history of hypertension. There was even a trend in the patients who had their first infarct. But these are the two main things here. And actually, this mortality reduction was present at 12 months as well. So this raises some really interesting questions in my mind. And I suspect that there are cleverer people in the audience here than me. Things that I would think of, though, might be that these were patients, the younger patient having their first MI, they had no collaterals. So they were really sick and they did benefit from an intra-aortic balloon pump. Just a hypothesis. Similarly, no history of hypertension. Does that mean that their vasculature is more compliant, less stiff? So maybe they couldn't support a pressure such as may occur in an older patient with a history of hypertension and a stiff vasculature. Anyway, I think things just to keep in mind here. So let's move on to the question of what does this mean for your practice? Well, my thoughts are that despite this critique here, I think this study tells us that the routine use of an intra-aortic balloon pump in our patients with shock can seriously be questioned. And I think this particularly applies to the patients who appear to be, quote unquote, in mild shock, just a little hypotensive. There's probably no role for an intra-aortic balloon pump in those patients. And again, we need to be vigilant in terms of, and aggressive in terms of our resuscitation, particularly with fluids in these patients. Urgent revascularization should absolutely remain our first priority. There is absolutely no indication for putting a balloon pump in a patient in shock and waiting to see whether or not they survive or not. That patient must go to the cath lab. That should be #1 priority. And as was seen in the previous talk here, and it came up in the discussion in this morning's session, very, very important to look for other causes of shock that maybe need the attention of a surgeon. So in particular, rupture. It's the commonest cause of death in patients who are hospitalized with acute myocardial infarction. Right ventricular infarction also needs to be looked for, and the treatment for this is very, very different. So again, I think that we do need imaging, whether it's echocardiography or a left ventriculogram at the time of angiography. We've got to be thinking about this. There's absolutely, I don't think, any role for treating these patients in the dark if they're in shock. We must know what's going on with the right and left ventricles and the valves. The mortality, this remains staggeringly high. This is absolutely unacceptable that we still have a mortality of 40% or more in our patients who present with shock. Many of these patients had ejection fractions of 30, 35%. That was what was seen in the shock trial as well. And yet you all have patients in your outpatient practice who are walking around with ejection fractions of 20, 25%, and they're not dying of shock. So there's a disconnect here. There are so many things about cardiogenic shock and the outcome that we don't fully understand. And I would say that the surrogate of hemodynamics is not a good one for survival. But I do think that there is a role for an intra-aortic balloon pump, and we certainly still use it if the patient has profound shock, as I described with the case, or in the patient who clearly has a very, very low blood pressure, maybe the one that you did not want to enter into a randomized controlled trial. And I would say especially if that patient is young. In our own practice now, we have the availability of LVADs. These patients could never get to a transplant so soon, so LVADs, surgical LVADs are used, and so a balloon pump might be able to get that patient to that LVAD. That's something we can offer today that we couldn't 10 years ago. And similarly, we are using inotropes and vasopressors, but we want to use those in the lowest dose possible so to avoid toxicity. And I think that's why in these very sick patients, that an intra-aortic balloon pump allows you to use these agents maybe at lower doses. Here's some data from Mayo Clinic. You can see here that between 2010 and 2011, for some reason, the number of intra-aortic balloon pumps we used in STEMI patients increased significantly. But you can see here that since the publication and release of the results from the IAB Shock 2 trial, the use actually has decreased. It's the lowest we've seen, but it's not zero. We still use it for severe cardiogenic shock. A couple of words about percutaneous LVADs with the impeller here on the left and the tandem heart on the right. Many of you may not have seen a tandem heart used before, but this is requires a transeptal technique. There's no question that these devices produce superior hemodynamics to the intra-aortic balloon pump, but in the small number of randomized trials, including a meta-analysis, there's absolutely no improvement in survival. The one thing it did show, in addition to the superior hemodynamics, was an excessive amount of major bleeding and vascular complications. So at the moment, I don't think there's any role for us, role for these as first-line therapy for cardiogenic shock. And this table just summarizes the comparison between the three different devices. And I'd just like you to focus on the size of the sheath. You can see here for impeller and tandem heart, very large sheaths, and that's why these patients will have bleeding and vascular problems. Ease of use, though. It takes a minute or so to quickly put a balloon pump in. It takes much longer to put one of these other devices in. But even more importantly, look at the cost. In the United States, up until a couple of years ago, there were about 100,000 intra-aortic balloon pumps placed per year across the nation. And the balloon pump itself costs about $800 to $1,000. But for impeller and LVAD, and these are disposable items that you throw in the trash afterwards, $26,000. What about high-risk PCI? It's all in the definition. We may all have a different definition of what high-risk PCI constitutes. And I'll just summarize the data here showing that from the BSIS-1 trial, which was negative, there was no difference between intra-aortic balloon pump or no intra-aortic balloon pump. Similarly, in the PROTECT-2 trial, no difference between the balloon pump and impeller. And in fact, I think we could just say here that it's very rarely needed. I'm sure it's overutilized in many labs, perhaps even in our own lab. It's a good standby option if the patient does get into trouble. But quite honestly, a lot of these high-risk PCIs with modern equipment now, it takes you longer to put the balloon pump in than it takes you to do the procedure. And so really, I don't think that there's a routine role for this. And I'm going to finish with a clinical case. And I will admit that this is my patient. I feel totally responsible for this patient, and it's a very sad case. I think it qualifies as a younger woman, and Harlan Krumholtz was talking about younger women this morning. Here was a patient with a non-STEMI. She wasn't diabetic, but she was a very heavy smoker. She'd had a recent CVA, normal LV function tested at the time of that CVA, which was just a few weeks before this non-STEMI. At angiography, she had 2 vessel disease, and we attempted PCI of the LAD and circumflex, but unfortunately there was a guide catheter dissection of the left main, completely occluded, 100% occluded, and we could not advance a wire across the left main occlusion. And we recognized that this was going to be extremely difficult from the moment it occurred, and although we tried, we immediately called for balloon pump but ECMO at the same time. So this is something that some of you may or may not have seen. She rapidly developed shock, but interestingly was awake with a systolic blood pressure of 50, talking to us. We actually, the ECMO team arrived within a few minutes. This is unbelievably fast. And within 20 minutes of the left main dissection, she was placed on VA ECMO. 20 minutes. 5 minutes later, she was moved out of the cath lab, and she was sent for emergency bypass surgery. Now, I'm convinced that she would never have survived the trip to the operating room if we had placed an intra-aortic balloon pump. I may be wrong, but I've talked about this over and over again with our surgeons, and everyone believed that ECMO kept her alive until she got to the operating room. This is a TEE. Remember, she had normal ejection fraction a few weeks before. I'm no echo expert, but you can see here that the LV is not working very well. And for those of you who don't look at a lot of TEEs, the LV is on the top and the RV is on the bottom. And it's interesting, actually, the anesthesiologist was concerned about the right ventricle not really functioning well. But this is important to keep in mind. This patient was on VA ECMO, and it'd be difficult to tell what the right ventricle was doing there because the right ventricle is now offloaded. But you can see here that there's very little cardiac motion here. And again, this is why I don't think this patient would have survived to the operating room with an intra-aortic balloon pump. But everything comes with a price. And here are the highlights of this woman's course. She was on ECMO for 8 days. She developed respiratory failure. She required tracheostomy. She developed left lower extremity ischemia due to thrombus in the iliac artery related to the very large cannula for ECMO. And a month later, she had a below-knee amputation. Her LV function never improved. She had continuing heart failure, and she underwent placement of a surgical LVAD as destination therapy. She was not considered suitable as a transplant patient, primarily because of her smoking history. And 3 months later, she was dismissed home. So I just show that case really just to put this talk into perspective, because we don't have all the answers for the treatment of shock. I hope that perhaps I've convinced you that we don't have to routinely put balloon pumps in patients with cardiogenic shock. I do think, though, that there is a place in selected patients, particularly those who are young and who have profound shock. And I think we should also remember that staggeringly high mortality that I described, and the fact that there's still a lot we don't understand, and that the hemodynamics are not necessarily a surrogate for survival. Again, thank you so much for your attention. If you do have any questions, there's my email address there.
Thank you, Malcolm. I think I was right in your introduction. I'm not sure, and you may confirm or disagree with my view about the role of IABP in cardiogenic shock. I think in cardiogenic shock you have a sequence of pathophysiological situation, and first cardiogenic shock is mostly hemodynamic collapse, but it's mostly, and then you have this multi-organ failure, and then you have this systemic inflammation syndrome. And my perception, and this is just a perception, is that if you use the balloon pumping just at the beginning, when you can prevent or stop this triggering of multi-organ failure and this systemic inflammation, probably it has a role. But if you wait when the cardiogenic shock is really established, probably does nothing, because you cannot really revert all the changes in metabolism and organ failure and so on. But I mean, this is just a speculation. So I'm wondering whether very early use of balloon pumping and cardiogenic shock, just in the right beginning, could be useful. Though if you go for a few hours, and that's actually age dependent. I think the elderly very quickly get into this cascade of complications. So it may be a time-dependent usefulness of balloon pumping.
I tend to agree with you. I think, though, we've got to make sure that we don't muddy or confuse the message. That the vast majority of people probably are not going to benefit from an intra-aortic balloon pump. That's my personal opinion. And I think, we can't ignore what I think was still a good trial. It was very inclusive, 75% recruitment of, shock patients. But I think you're absolutely right. Early on in that patient who clearly has profound shock, just like the patient I described at the beginning, that's a patient that I can tell you we would have no hesitation at all putting a balloon pump in. It's relatively cheap compared to Impeller. It's easily put in. But you're absolutely right. Then afterwards, what happens? If the patient gets better and you can get them off the balloon pump within a few hours or next morning, that's fine. But you bring up the point of multi-organ failure, which I didn't talk about here, and the systemic inflammatory reaction we see, which we don't fully understand. Remember, the TRIUMPH study was stopped for futility. So in those patients, particularly the young patients who might have another end goal, such as a destination LVAD or a bridge LVAD to transplant, so I'm particularly talking about the young patients, those are the patients that if they continue in shock, within 24 hours, we probably want to provide better mechanical support before they go into multi-organ failure. And I don't know how many cardiac surgeons we have still in the room here, and particularly those who deal with transplantation and LVADs, but our surgeons will say, we want to see those patients sooner rather than later. They don't want to operate on these patients when they're in profound renal and hepatic failure, or develop severe ARDS. So the balloon pump first, and if it's clear that the patient is sinking, I think that's when we start thinking about percutaneous LVADs or surgical LVADs.
So, any comments, questions? Kirsten? No.
I'm sorry. Thank you for your presentation. Another issue, I think, is the context of the patients in this trial. A lot of patients, if I am not wrong, were on hypothermia, suggesting that they had an out-of-hospital cardiac arrest. These patients, many of them have an enhanced inflammatory response, making it possible that the beneficial effects of pumping were not as good as in patients with pure cardiogenic shock. Do you think that the treatment of a patient with hypothermia should make any different in the indication, in the management of balloon pumping?
Yeah, it's an excellent question, and I think the simple answer is yes. I think we have to treat those patients a little differently. We rely heavily on our intensive care anesthesiology support for those patients. These patients can basically have vasoplegia, and we have to support them with potent vasopressors. On the other hand, simplistically as cardiologists, I think we've been told before that if you have a patient who has, an inflammatory shock state, and particularly, with low vascular resistance, there is no role for an intra-aortic balloon pump. But that actually has been challenged in the last few years, and there's a number of animal studies suggesting that the balloon pump might have a role in supporting the circulation there. But in general, I think your interpretation is correct. Those patients probably have confused the interpretation of the trial a little, and we probably need to treat those patients a little differently.
Yeah.
To tell you that I fully agree with what you said. The sooner the better for us. The sooner you have the patient in a more stable hemodynamic condition, it's the better for us as surgeons. I just wanted to say that it's something related. A nice study will be also about the patients who are getting an ECMO very soon, not to save only of the cardiogenic shock with the idea of saving the heart, but also as a donor. There is more and more evidence that people doing liver transplantation, kidney, and so they can try to keep the hemodynamics, even if we know that maybe the heart or even the brain is not going to work anymore, to keep it. So they maybe also we can know some more about the hemodynamics of all these LVAD systems.
Yeah, I would agree, and I think that as cardiologists, if we're working in the intensive care unit, as ECMO becomes more frequently used, I think we all need to sort of begin to learn to understand how ECMO is set up and how it's used, what its limitations are, the pitfalls, even managing like severe right ventricular failure with a right ventricular infarct, with RFADs and things. So the whole scene has changed. It's becoming more complex, and as cardiologists, we need to understand these modalities much better so that we know when to ask at the appropriate time and what to ask for.
Okay, so we have time for one last short question.
Yeah. Is regarding the LVADs and cardiogenic shock after primary PCI. As you have presented very well, there are very small trials suggesting no benefit. And as you mentioned properly, it's because the complications of these devices offset the potential benefit. In my institution, which is very fan of these devices, maybe because we have 30 years of transplantation program, we understood that we have to change this 4 years ago, and then we implemented a program of assistant devices with 4 people, 4 cardiologists, young people, staff, that has been trained specifically for this purpose. And then we presented in the last national cardiology meeting in Spain 100 consecutive patients with cardiogenic shock after primary PCI and balloon before the implementation of the program, and 100 in the same condition after. And we have seen a dramatic increase in survival. The patients not only reach the recovery, but also the patients that are undergo transplantation get the transplantation better, and transplantation survival is better in these patients. And I think because the question is not to put the device or not, is you have the program. And the program means more implantations, more devices in myocarditis, in bronch transplant, post-ops, myocardial infarction, of course. Then I think LVADs are very good if you have trained people, specific trained people in the coronary unit or the cardiology critical unit, doing these procedures frequently, and they get more and more and more well performance every year. And then it's a very good resort for patients with in these conditions.
Well, I appreciate the comment, and I'll just add that I would agree that, you know, actually it's quite, once you've put one or two of these in, they're actually very easy to put in. It's all the aftercare that's important. So, you know, the nurses and the residents looking after the patient in the CCU, but okay.
Okay, thanks a lot. It's been a very interesting session. Thanks to all the speakers. And now we move on to this next session. We'll have some very nice clinical cases.